Welcome to When to Consider Surgery. Please remember the information provided in this web seminar is not intended as a substitute for your physician's guidance and care. My name is Sarah Rothschild. I'm the VP of Program Services, and I am your moderator for today. I would like to introduce our presenter today, Dr. Jason Sicklick, who is a general surgeon and surgical oncologist at Moores Cancer Center at UCSD, who specializes in treating hepatobiliary diseases and sarcomas, including gastrointestinal stromal tumors. He has a special interest in abdominal and retroperitoneal sarcomas, primary liver tumors, and colorectal and neuroendocrine cancers that have metastasized to the liver. I would like to now transfer the presentation to Dr. Jason Sicklick. You may begin.
Good afternoon. Thanks everybody for joining us today. And thank you, Sarah and LifeRaft for setting this up, and such a great opportunity for all the patients to learn about the role of surgery for treating gastrointestinal stromal tumor. Why don't we get started? So just as a disclosure, here are my research funding and some consultant disclosures I have. So our agenda today will basically span the gamut of large GIST to small GIST to metastatic disease to the role of palliation. But I first want to start off just giving some basics about GIST. So GIST, or gastrointestinal stromal tumor, arises from the interstitial cells of Cajal, which are the pacemaker cells of the GI tract that control peristalsis of our intestines so that we don't have to think about our intestines moving after we eat. These tumors occur within the wall of the stomach or the remainder of the small intestine and are marked by expression of two common markers, being DOG1 and c-KIT or CD117. Around the world, the incidence of GIST varies depending upon which study and which region of the world you look at, but the incidence ranges from anywhere between about 2 cases per million to about 20 cases per million patients, but the average age of most patients is in the mid-60s around the world. So GIST can occur throughout the GI tract. We know that it occurs anywhere from the esophagus to the stomach to the duodenum, which is the first portion of the small intestine, to the remainder of the small intestine, all the way into the colon here, as shown in the by the area designated large intestine, and then finally it can occur in the rectum. GIST have very heterogeneous biology. They can present as very small tumors to very large, massive tumors, presenting with locations ranging from the esophagus all the way to the rectum, as I mentioned. There's a lot of questions that come up when I see patients in clinic about whether GIST is a benign or a malignant tumor, and it's not really a black and white disease. It's really more on a grayscale from what we consider very low-risk tumors to high-risk tumors. And there's two main features that determine whether tumors are low-risk to high-risk, and that's the size of the tumor and the mitotic index. The size, we generally go by centimeters. As you can see here, 5 centimeters is roughly about 2 inches for those of you that are more familiar with using the inch. And the mitotic index refers to the number of cell divisions that are occurring within the tumor. So normally when a cell divides, basically the DNA replicates within the cell. Those chromosomes then divide and form two cells. The mitotic index refers to the identification of mitoses, where basically the cells are splitting and the chromosomes are lined up in the middle of the cells. And these two factors are really what play into the most common risk assessment tools that we use for characterizing GIST. And as I mentioned before, these come in from risks from very low risk of metastasizing to very high risk of metastasizing or recurring. As you can see here, for the very low and low risk tumors, these tend to be very small tumors, so less than 2 centimeters or less than 5 centimeters with low mitotic index, meaning the number of cell divisions per 50 high power fields. Intermediate risk tumors are those that are a little bit larger or those that have a higher mitotic index. And then finally, the high risk tumors are those that are larger or have a high mitotic index or have a combination of both. And these are often the ones that are a little bit on the smaller side but have a higher indices, or those that are outside of the stomach. So being outside the stomach is another risk factor for a little bit more aggressive biology. And then the final thing I'll point out here is that one of the other important factors to consider is tumor rupture. And this is a critical factor that we'll talk about a little bit later when it comes to surgical interventions. So surgery itself. So surgical resection is the primary treatment for GIST, and this is potentially curative in some patients. So what are the goals of a GIST operation? So the first goal is to have complete resection of the tumor. So total gross resection is a terminology that we'll often use. The second goal is to ideally get negative margins microscopically, meaning that when you take out the tumor and the pathologist looks under the microscope, that they can not identify any tumor cells at the edge where the tumor is removed. And then the third thing is that the tumor capsule, or the outside lining of the tumor, is intact without rupture. And that goes back to that what I mentioned here before, is that tumor rupture being an important part of this. So how do we make decisions about surgery? So there's a couple of things that we need to weigh, and it really comes down to risk assessment. And so what are the risks of an operation that might be an individual considerations for a patient? One being their comorbid medical conditions, meaning there are diabetes, high blood pressure, heart disease, history of strokes, medications that they're on that might be an issue in terms of bleeding. The patient's physiologic age, meaning that just because somebody is 65 years old, sometimes people that are 65 chronologically may actually have more of a physiologic age of a 75 or an 85-year-old, and vice versa. Sometimes patients that are in their mid-80s are in great shape, and somebody that's in their mid-60s is not. So we really have to weigh the chronologic age versus the physiologic age of a patient. The second factor is how does we see a role for this patient benefiting for surgery? So it's always a risk-benefit analysis. So what are the potential benefits that we might obtain? So one is the chance for cure of this disease. So those tumors that have more aggressive biology may be less likely to be cured. The chance of resetting the clock, and what I mean by that is that somebody in the setting of metastatic disease that we'll talk about later, while we might not be curing that patient with resection, we might be slowing down the progression of their disease over the long term. And then the final benefit potentially being palliation, meaning the chance of alleviating symptoms from the tumors, whether that's pain, bleeding, obstruction of the intestines, all these symptoms can cause be reasons for wanting to think about resecting a tumor. Now, in terms of, as a second part of the decision making, besides what is the goal of the operation, is technical factors. Where is the tumor located? What's the biology of the tumor, and how many tumors are there? So I like to think about diseases in terms of the biology and the location as really the two major factors. Now, as a surgeon, our ultimate goal is to try to remove tumors, but we have to be realistic in that the biology of these tumors can be very aggressive, and we need to recognize the fact that biology often beats the technique when we're talking about resecting tumors if it's bad biology. So we need to pick the right patients for the right operations. So a way to think about this is whether patients have good biology and bad biology, or good location and bad location. And so I'll go through some examples of what I mean by this. So what do I mean by a good location and good and good biology. So as an example, a 4-centimeter tumor in the stomach or a gastric gist that with a low mitotic index, so something, let's say, sort of on the edge of the stomach right here, would be considered a better biology and a fairly easier place for a resection. Now, the flip side is you could have a smaller tumor, so only 3 centimeters, but in a bad location, being the esophagus, which is a fairly fixed area within the body. That's a small area and a small diameter and not easy to get to, or down in the rectum. Even though this tumor has a low mitotic index, it still has bad location. Now, alternatively, you could have a 15-centimeter small intestine tumor, which would be right in the middle of the small intestine here, with a high mitotic index, and that's actually an easier operation than a 3-centimeter esophageal or rectal gist in those situations. And then finally, you might have a 5.5-centimeter duodenal gist. So the duodenum is this portion of the intestine right here, basically that wraps around the pancreas, which is sitting where this sort of white area is where the arrow is sitting, with a high mitotic index, and that's a pretty difficult place to be operating. So what are these bad locations? So let's just talk a little bit more about them. So the first one is the esophagus or the gastroesophageal junction. And why I say it's a bad place is because even though it might be a small tumor sitting right at the end of the esophagus or right straddling this area might lead to the need to take out the entire stomach, just because if we take out just the top part of the stomach, the amount of reflux that patients get is pretty significant, and it's actually fairly life-debilitating to the point that it's actually better to take out the entire stomach than just take out the top of the stomach. And so doing an entire stomach removal can have significant morbidity also and changes in somebody's eating habits and lifestyle. The duodenum, as I mentioned, wraps around the pancreas here. And so in order to remove the entire duodenum, if let's say there was a large gist sitting right in the middle of the duodenum here, actually requires what we call doing a Whipple operation, which is taking out the head of the pancreas because the pancreas is draining into the duodenum, the end of the bile duct because the bile duct actually drains into the duodenum, and then reconstructing all that. So you're basically reconstructing the bile duct, the pancreas, and then reconstructing the intestines again. So sewing 3 connections, which is a pretty significant operation for potentially for a smaller tumor. And the third location being the rectum. As I mentioned before, this is a small area, and sometimes with rectal tumors, reconstruction can be difficult, and sometimes in certain situations somebody might need to have an ostomy bag and in order to ensure resection of the tumor with appropriate margins and maintaining an ability to have normal bowel function. So these are the situations where we want to think about giving neoadjuvant or imatinib or treatment up front prior to an operation. So marginally resectable tumors, so things that are locally advanced or large, where we might think that removing the tumor might not be completely feasible, where there are high likelihoods of being positive margins, so that's areas like the esophagus and the rectum that are very small areas to be operating in, areas where tumors are involving adjacent structures, where there's an opportunity for a less extensive operation, and as I described for the Whipple operation with a duodenal tumor, sometimes if we can shrink a duodenal tumor down, we can remove the gist without having to remove the entire duodenum and perform the Whipple operation. And then the last situation being is number 5 there, shown, which is the potential for a safer operation, meaning less blood loss or a lower risk of tumor rupture in those kind of situations where you're concerned about that being a possible. Now, besides these bad locations, there's also a combination of bad location and bad biology, and this is an example of a tumor that's a very large tumor that's sitting right below. This is the tumor here. This is the stomach here. This is the liver, shown in the right upper side here of the abdomen. And this is a very large tumor that's encasing or surrounding blood vessels, such as the main blood vessel that supplies the liver. This is certainly not a resectable tumor, and this would be an example of where giving therapy up front could be used in order to shrink this tumor down. And you can see here there's pretty significant tumor shrinking down, and after several months, we can see near resolution of this tumor. And while we do see some fluid in the abdomen here associated with resolution of this tumor, we see that almost that entire tumor is gone, allowing us to then eventually take the patient to the operating room for an operation to remove the tumor. So in summary, this part of the talk, neoadjuvant imatinib, or giving imatinib therapy ahead of time, is generally felt to be safe for patients with GIST. We do give it on a regular basis for patients with GIST in some of these difficult locations, as I mentioned, being the esophagus, the duodenum, the rectum, or very large tumors where we think that we might be able to shrink the tumor enough that we can save adjacent organs. But it does come with risks. It does come with the risks of toxicity from imatinib, and we don't have time to talk about that today, as well as risk of sometimes when the tumors respond very well, they sometimes, we've seen them bleed before due to basically the tumors dying off and then bleeding into themselves as they respond to therapy. It really comes down to thinking about the tumor location and the tumor biology as the two probably most important factors in determining whether something should be operated on and when it should be operated on. If we're going to do imatinib therapy or some kind of neoadjuvant therapy, we generally try to maximize the response. This can take as long as sometimes 6 to 9 months for patients to have a maximal response, meaning that the tumor is continuing to shrink, but eventually by somewhere about 6 to 9 months it stops shrinking anymore, and therefore at that point we don't see any more benefit to getting the tumor to shrink anymore. But in situations where that patients are developing toxicity, or their tumor is not responding anymore, or if we feel that even if the tumor shrinks a little bit more, it's not going to significantly change the operation, those are situations where we might consider stopping the imatinib earlier. In terms of when to stop the imatinib before an operation, it can be stopped basically within a day or two of the operation, and it can be started as soon as somebody is recovered from the operation and is able to tolerate pills. Finally, we don't have time to really delve into it today, but we certainly would want to consider what the mutation analysis is of the tumor before giving imatinib, if we're going to do this in the preoperative or neoadjuvant setting, just because certain tumors with mutations such as PDGFR alpha mutations are resistant to imatinib, and so therefore there would be no role for giving imatinib in those situations where the drug is known not to work, and so therefore there's no benefit to giving the drug if the only risk is developing toxicities from the drug. So with that, we're going to move on to another subset of GIST that raises a lot of questions, which is the small GIST. So those less than 2 centimeters, and these go by lots of different names depending upon which studies you read in the literature. People talk about ICC, or interstitial cell of Cajal hyperplasia, minute GIST, GIST tumorlets, microgist, mini GIST, very small GIST, small GIST. Obviously they're all sort of a gradient, if you will, but referring essentially to the same thing. There was a German autopsy study done about 12 years ago now looking at small GIST, and they performed autopsies on 111 patients. And they found that 35 patients, so about 32% of these patients, had small GIST within their stomach. And these were patients that had previously unknown GIST, and so this was identified at the time of autopsy. They then performed additional 98 consecutive autopsies that they looked at, and basically about a quarter of those patients had small GIST. These patients tend to be older, with an average age of 75, but these tumors tend to be very small, so an average of about 3 millimeters in size. And these tended to have most commonly KIT mutations based upon testing that was done sort of in an earlier era of genomic testing. But what this suggests is that small GISTs, often and even on the millimeter size range, are very common in patients over 50 years old. Others have looked at the incidence of small GIST across many studies, and if you combine many of these studies from a combination of Europe and Asia, about 40% of the studies reported patients having small GIST, but none of these studies reported any evidence of recurrences of these small GISTs after removal. Now, several years ago, our group looked at the data from the United States and assessed patients that had small GIST less than 2 centimeters that had been resected at the time of an operation or had been coded within the prior coding system as being malignant. This represented about 378 cases of the 6,142 cases in this U.S. database, representing about 6%. These tumors were fairly rare, representing only about 4.2 cases per 10 million patients, as opposed to the I previously described that within the U.S. it's about 6.8 cases per million patients overall for all GIST. So this represents just a small fraction of these. Now, if we look at the mortality of those patients that had a small GIST and had one of two things, one being that they were coded as malignant, or two, that they were removed at the time of an operation, there was a significant mortality associated with these, meaning risk of dying from these. So about 1 in 8 patients died of their tumors within 5 years of removing their tumors. And the data suggested that there was a trend towards them doing slightly better if their tumors were removed, but it was not statistically significant. But what this suggests is that these small tumors, these tumorlets, if you will, are common, representing occurring in about 20 to 30% of patients over the age of 50 based upon autopsy studies. And obviously the caveat being there is that these patients had to have passed away in order to have their autopsy done, so they may have some underlying reasons why they had developed these tumors in addition to the reason why they had passed away. Somewhere about a quarter of the patients in the European and Asian studies had small GISTs. If we look at the small GIST based upon the data that we had published in our study from the United States, it only represents a small fraction of small GISTs that actually undergo removal. But we need to be vigilant of the fact that a subset of these small GISTs don't have what I would consider quote-unquote benign appearing biology, that they can have aggressive biology. And so we need to be vigilant about this. And so how is this, can we be vigilant about this? Well, if somebody has a small GIST, it needs to get worked up. This can be done through endoscopic ultrasound and fine needle aspiration or through imaging. Based upon endoscopic ultrasound, the NCCN guidelines recommend looking for high-risk features, including irregular borders, cystic spaces or cysts within the tumor, ulceration, echogenic foci, meaning sort of referring to the heterogeneity within the tumors, as you can see here. And if that's the case, additional workups would be recommended. The NCCN guidelines in the United States recommend a multidisciplinary evaluation by a GIST expert in these situations, as well as pathologic confirmation of the diagnosis, cross-sectional imaging being a CT scan or an MRI, consideration of chest imaging, and then finally consideration of testing for gene mutations when medical therapy is planned for patients. So how do we risk stratify small GIST? Well, small GIST can range anywhere from very low risk to very high risk. Obviously, the tumor size is small, and that would be generally a low risk factor. If the mitotic index is low, then they would be considered very low risk, and then often we will just consider watching these. But if they have a higher mitotic index, this would certainly put this patient in the intermediate risk range. And if they have a high mitotic index over 10, this would put them in the high risk category. and these are certainly tumors that should be removed. So going back to sort of our algorithm, if their patient has a small GIST with a low mitotic index and no high-risk imaging features based upon the endoscopic ultrasound or the CT scan, these are patients that we should, there's no intervention recommended. Now, what are some of the controversies? And we don't have a lot of answers for some of these questions within the small GIST world. So what is the role of resection for a small GIST? And so the first question I'll go to there is resection associated with improved survivals in higher risk small GIST? So if we look at the data that we published in the Journal of Gastrointestinal Surgery in 2016, if we look at patients that had surgical resection for a small GIST and had a small GIST, those patients that had surgical resection had a lower mortality than those patients that did not have an operation to resect their tumor. If we look at the cancer-related mortality in those patients, again, those patients that underwent surgical removal had a better, lower cancer death rate than those patients that did not. If we then tease out the patients that had other cancers in addition to their GIST, and we remove those patients that had additional cancers, which is roughly about 1 in 6 patients with GIST will have another cancer. If we look at the GIST-specific mortality, sorry, my mouse is a little bit jumpy. The patients, there was a small number of patients that did not have surgery, and their trend was towards a benefit to removing the tumors, but it was not statistically significant. What about young patients with small GIST? So as an example, what should we do with a 45-year-old with a 1.5 centimeter GIST? And there really is no good answer for this question. One of the things to consider is are we going to follow this patient for the next 30 plus years, expecting that their tumor will likely grow over time? In general, the current recommendations are to consider CT scan or MRI or endoscopic ultrasound every 1 to 2 years for follow-up. But then the question becomes is how long should these patients be followed, especially if they're on the younger side. There is no good recommendations for this at this point, and it's something that on an individual basis, patients need to speak with their physicians about whether they're should be considered for surgical resection. And then finally, what are some of the approaches? Is it optimal to do a full thickness, taking the entire wall out, or just to do an endoscopic submucosal dissection, meaning just carving the tumor out of the wall of the stomach and closing it up, as an example? And so these tumors tend to grow often. These small ones are often discovered within the stomach just because patients tend to get upper endoscopy, and this is the most common place we see these. They can grow inward or outward. There's several different approaches for doing this. Our group has been very active in removing the small ones in the upper portion of the stomach via a combination laparoscopic and endoscopic approach where we're working inside the stomach, and this is actually images from our group showing where we can actually remove the tumor from the inside of the stomach. Several other studies have been reported out of Europe, Asia, and the United States looking at other approaches to either cutting out the wall of the stomach and then suturing it back up, to sort of pulling the stomach inward and then clipping, or finally basically dissecting within the wall of the stomach, cutting it out, the tumor, and then suturing it back up. None of these have been compared head-to-head, and it really comes down to what your surgeon is most skilled at and most comfortable with. So to summarize the small GIST section, it's important to stay vigilant and not to underestimate the risk of small GIST. Many of these will likely be very low risk and can be followed, but an appropriate level of vigilance should be maintained, as a subset of these will have worrisome features and should be removed. In terms of the follow-up of these and for patients that are younger with smaller GIST, there are no clear guidelines at this point for how to manage these over the long term. Ultimately, if we're going to proceed with resection of one of these tumors, like larger GIST, we should strive for a safe removal of the tumor with the goal of getting negative margins in appropriate surgical candidates. The next section we're going to talk about is stable metastatic disease. This is often a question that comes up of how to manage patients with stable metastatic disease. So as many of you know, GIST can spread. It can spread in multiple different fashions. It can grow inside of the liver as liver metastases, as shown here. It can spread via the peritoneal surface, being the lining of the abdominal cavity, as shown here. And in some rarer subsets of GIST, including those with succinate dehydrogenase deficient GIST, as well as some of the mutant GIST that have gene fusions, nodal metastases to lymph nodes are more common. But this is a rarer subset of patients with GIST. So going back to what I originally alluded to in the risk stratification of GIST, tumor rupture is a poor prognostic factor. And as you could see from the risk stratification that I showed earlier, even a patient that has a very small GIST that ruptures, even if it's less than 2 centimeters, that patient automatically gets risk stratified as a high-risk GIST. If we look at the probability of disease coming back, on this Kaplan-Meier curve, this is the time on the x-axis here, and the probability of recurrence on the y-axis. Having no rupture, the risk of it coming back is significantly lower than the risk of it coming back if tumor rupture occurs. And so we need to be vigilant about how we're thinking about manipulating these tumors and how we're approaching them. So often we see patients that present with metastatic disease following tumor rupture. And so then the next question becomes, is when should we consider removing these tumors? And so it comes back to those two main factors that I talked about before, is location and biology. So when do we consider doing a metastasectomy or removal of metastatic disease? So here's the big picture, and then I'll show you a little bit of data about why these would be some of the considerations that we use in our decision making. The first one being is a long disease-free interval, meaning that somebody had an operation, perhaps their tumor did rupture or perhaps their tumor didn't rupture, but the amount of time between when their first operation was and the tumor comes back is a long period of time, and that's long being a relative term. And it's something that you have to take on a case-by-case basis in terms of the biology of the disease, and something that each individual patient and surgeon will need to agree upon. The other factor being the progression-free survival on treatment, meaning that if somebody has metastatic disease and they're receiving some type of tyrosine kinase inhibitor or TKI therapy, that their disease is well controlled. So ultimately, when you look at both these factors, and number one, they come down to biomarkers of good disease control or good biology. If somebody has responsive disease to these tyrosine kinase inhibitors, including imatinib, and they don't have progression of their disease, again, it's a better biomarker of disease control and better biology. We know that patients that are earlier in their lines of therapy tend to do better than in later lines of therapy. And the same thing goes for when we should think about being more aggressive in terms of surgical resection. So we'd prefer to do a metastasectomy following first-line imatinib than following third-line regorafenib, as an example. Resection is also dependent upon the number of tumors. I often say to my patients that imaging is fairly unreliable and often underestimates the number of metastases that we see in the operating room. And time and time again, I find that to be the case. But in properly selected patients, even if there's large numbers of tumors, if we can remove all of those tumors, then surgical resection may be appropriate. So where are the most common places that these go, and kind of would be that within the liver or hepatic. Here's just sort of a cross-section example of what you often will see on CAT scan and the way it looks. The peritoneum, which is the lining of the abdominal cavity, and so all these sort of white here, lining the intestines and lining this area is the peritoneum. We're less likely to operate within the retroperitoneum, which is the back portion of the abdomen where the main blood vessels like the aorta and the vena cava and the kidneys sit. Lung metastases and bone metastases are typically things that we don't go after in terms of resection, with perhaps rare circumstances where that might be the case, but that is not. Those are fairly uncommon places for GIST to metastasize to, and in those situations, often patients are not resection candidates. What are the technical factors? I've got 3 listed there. One is the ability to obtain a complete resection. The second being the ability to preserve adjacent organs and structures. The third being ability to perform a safe operation. And here's just an example of a patient with pretty significant disease where we took the patient to the operating room in order to debulk her disease. So what is the data to back up some of these things, these concepts I've presented to you today? Well, as I said to you originally, biology beats technique. So we have to be good about picking the right patients for the right operations. So if patients have responsive disease to treatment or a longer progression-free survival, they tend to do better than those patients with disease that is resistant to treatment. Here's some additional data demonstrating similar concept that if we can completely resect the disease, meaning that we can achieve either microscopically positive margins or negative margins versus leaving disease behind, which is R2, patients do better than if we leave gross disease behind. If patients have progressive disease, they do worse than if they have non-progressive disease, meaning if their tumors are responding to therapy, they do better than if they're not. So the take-home would be is that we want to shoot to do complete resection in patients that are responding to therapy, and that there's minimal role for doing an incomplete resection because it doesn't benefit the patient and it doesn't seem to prolong survival. So taking somebody to the operating room and taking a couple of the tumors out, knowing that most of the disease will be left behind, is not beneficial. And then here's some additional data, combined data from the Memorial Sloan Kettering group and the Brigham and Women's group, showing similar data suggesting that cytoreduction of patients with responsive disease is the best scenario. Those that have stable disease would be the next best, and then if they have unifocal progression, meaning that one tumor is growing but all the rest are shrinking, is the sort of next best option, if you will. And then the least ideal option is those patients with multifocal progression. So to summarize, although surgery remains the only potential curative treatment, patients who undergo complete resection may still experience local recurrence or distant metastases, and that therapeutic strategies that combine surgery with drugs such as imatinib represent the best approach to maximizing outcomes. And finally, surgery in the setting of metastatic disease in the absence of multifocal progression on treatment with drugs like imatinib is associated with at least similar outcomes, if not better outcomes, to putting patients on second or third line treatments. But this is all a discussion between the patient and their surgeon, and it needs to be individualized on a patient-by-patient basis. So the last disease type I want to talk about briefly is palliative operations. So GIST can often present as asymptomatic disease. Patients can sometimes present with nonspecific symptoms of obstruction, such as nausea and vomiting or abdominal pain. distension or early satiety, meaning getting full very easily. They can present with either a slow bleeding, such as low blood counts or anemia, melanoma, which is black stools, or they can present with acute bleeding. And then finally, the tumors can perforate or rupture, and patients can present with acute onset of pain, fevers, or elevated white blood cell count. So what do we define as palliative surgery? So palliative surgery is doing an operation within 6 months of somebody passing away. How do we predict whether somebody's going to pass away or not? Well, we're not very good at it. There are some scoring systems, such as the Eastern Oncology groups, Eastern Cooperative Oncology Groups, or ECOG score, which is a marker of somebody's performance status. There's fatigue scores, the serum albumin, which is a marker of nutrition status, are different ways that we can have general ideas about the fitness of a patient. But overall, as physicians, we're not always so good at predicting who's going to do well versus not. In general, if you look at it across the board, palliative surgery across all disease types, there are high complication rates, roughly about 15%. And so with that being said, palliative surgery is really dependent upon a triangle of talking between the patient, the surgeon, and the family, and everybody coming to agreement about what is the best approach for improving the quality of life of a patient, but being realistic. And so we need to be cognizant of the survival prediction based upon the extent of disease, and we're still, as physicians, not always so great at this. About half of patients in general that have cancers will still receive chemotherapy within 30 days of dying, which is probably not appropriate in a lot of situations. It is appropriate to say no when it's not going to benefit somebody, and we need to, as a group, in this triangle, have realistic expectations of when to expect there to be a benefit from an operation. The final section I'm going to talk about is surgical approaches, and this is really a balancing act between cosmetics and recovery and oncologic outcomes. Whether something's an open operation or a laparoscopic operation, it's truly just a means to an end, and there are advantages to laparoscopic surgery, including smaller incisions, less pain, shorter lengths of stay, decreased admissions to the intensive care unit, and then there's lots of data suggesting that there's no differences in oncologic outcomes in many cancer types, including GIST, and this is one example of a study showing no difference in oncologic outcomes between laparoscopic and open. But there's a lot of different questions that need to be asked in determining whether somebody is truly a candidate for laparoscopic versus open. And I've bullet pointed them here over the next couple of slides. So these being tumor-related factors such as, can we get the whole tumor out safely? Is the tumor small enough that we can actually manipulate it laparoscopically? A very large tumor is not technically feasible to manipulate laparoscopically. Is the tumor involving other structures that might preclude us from doing this laparoscopically? Is this even safe? And then if we're able to get this out laparoscopically, how big is the incision going to be? If it's going to be a very large incision, well, it may not be of any more benefit than doing it as an open operation. Going back to the tumor rupture issue, is there a risk of the tumor rupturing? Well, if that's the case, you're better off having an open operation and not rupturing your tumor than having a laparoscopic operation and it rupturing. Is the tumor going to be stuck to adjacent organs? Is there multifocal disease? Sometimes laparoscopic surgery is great for one tumor in one location, but if you're going to be throughout the abdomen taking out tumors all over, maybe multifocal disease should be better treated in an open operation. And then finally, the tumor factor being, is there a role for shrinking the tumor down and being able to convert an open to a laparoscopic type of approach for a tumor? There's obviously patient factors. Is the patient an appropriate surgical candidate, or are there other medical problems that may preclude them? And has the patient had prior operations? Sometimes having prior operations precludes somebody from having a laparoscopic approach. Finally, there's surgeon factors. You need to ask questions such as, whether your surgeon is skilled or comfortable doing a laparoscopic approach, because ultimately a surgeon is going to do what they're best at, and that's what they're most comfortable with, and that's where they're going to get their best results. So in summary, it's critical that patients with GIST be evaluated by a multidisciplinary team of surgical oncologists as well as medical oncologists, radiologists, gastroenterologists, and pathologists in order to coordinate surgical resection and think about targeted therapies in order to maximize clinical outcomes. I just want to conclude the talk with a couple of bullet points. First, although surgery remains the only potential cure, patients who undergo resection may still experience local recurrence or distant metastases, and that is where the discussion about postoperative or adjuvant therapy comes into play. We don't have time to talk about that today. Therapeutic strategies that often combine surgery with targeted therapies such as imatinib often represent the best approach for maximizing outcomes. In selected patients with metastatic disease, we can think about doing operations when we're combining a combination of drugs plus metastatectomy where we can remove all visible disease. And finally, surgery for palliation is often a complex decision-making that requires involvement of the patient, the family, and the surgeon. And so therefore, these need to be personalized on an individual basis in terms of what is appropriate for surgical resection. And with that, I'm going to stop, and I'm happy to answer questions. If you have additional questions or something comes up, feel free to send me an email or a message via Twitter, as you can see there. And thank you very much for the opportunity to talk to you today about surgical therapy for gastrointestinal stromal tumor, and I'm happy to answer questions.
Great. Thank you very much, Dr. Siklik. We really enjoyed your presentation today. I'm going to now begin with asking you the first question. And by the way, if anybody wants to ask questions, you can use the Q&A chat feature through the platform. Okay, first question. Any genetic studies why Asian population has higher incidence of GIST?
It's a great question, and there have not been any genetic studies. It's something I'm certainly interested in trying to figure out. As in San Diego, we have a large Asian American population, and I do tend to see a lot of Asian Americans with GIST, but I don't have an answer as to what is the underlying reason, whether it is genetic, whether it's dietary, whether it's environmental, or something else that we don't know might be putting patients potentially at higher risk for developing GIST in the Asian population.
Okay. We're still waiting for some more questions to come in, so feel free to ask questions in the chat feature. I know that there are questions that come in from patients about preparing for surgery. Do you have any recommendations when a patient gets admitted to the hospital, what they can do to best prepare for surgery? I know sometimes there's concerns about potential infections being in the hospital. Do you have any insight on that?
In terms of preparation, the better shape an individual is in before their operation, the better shape they're going to be afterwards in terms of recovery. It's important that patients remain physically fit and are trying to get exercise and walking and going up and down stairs in order to remain as physically fit as possible prior to an operation. Would be my first thing. And along those same lines, eating a healthy, well-balanced diet is important. There is no specific diet that should be eaten before an operation, but just staying in, as optimizing your health as much as possible. Patients will often come in and suddenly, they've identified that they've been diagnosed with GIST, and now they're going to take 1,000 vitamins and completely change their diet and everything else they've done for the last 40, 50, 60, 70 years of their life, realistically that's probably not going to help at that point, but just being everything in moderation is probably the best advice I always give, and in terms of how to approach diet and exercise and everything else prior to an operation, and in terms of people trying to change their complete lifestyle when they've been newly diagnosed with a cancer.
Okay, great. The next question is, please review the bottom line for patients with liver metastases and rationale for no surgery option. Is a tumor rupture the biggest factor?
There's several factors that come into resection of liver tumors. One is that in order to resect tumors in the liver, you need to maintain that there's blood flow into the liver and out of the liver, and that there's an adequate amount of liver reserve left over after the operation. Removing some liver tumors and not others is not beneficial, and in fact that can actually exacerbate the problem, because when part of the liver is removed, it results in the other parts of the liver growing, and if tumors are left behind in those portions of the liver, that can actually, the same growth factors that tell the liver to grow will also tell the tumors to grow. So along the lines of obtaining, of cytoreducing or removing all metastatic disease, it's critical that if you're focused on doing this in the liver, that all visible disease be removed. And sometimes that's just dependent upon the biology, and often it's more dependent upon the tumor locations, and that's where having a liver surgeon that's experienced at doing liver surgery and that can safely preserve liver volume, but yet take all the tumors out is critical. But sometimes, depending upon where the location of the tumors are, that may not be possible. And so it really comes on an individual basis whether removing liver metastases is safe and feasible or not.
So the next question is, just tumors often metastasize to the liver or peritoneum. You mentioned the liver. Can you talk about how much the peritoneum might be different in terms of biology and or surgical risk?
So biologically, it's a great question. I don't think we know the answer. I don't think anybody's ever compared the biology of liver metastases versus peritoneal metastases versus lymph node metastases in patients with SDH-deficient GIST. Often peritoneal disease is really limited by, the ability to remove peritoneal disease is often limited by the involvement of the small bowel or the small intestine itself. The mesentery, which is where the blood vessels are, and the fat that's adjacent to the small intestine, often those implants can be removed fairly easily, but if there's significant disease on the small intestine itself, where there would be significant loss of the small intestine, that would compromise absorption of nutrients, that would be a situation where peritoneal disease might be precluded from being removed based upon just the volume of disease.
Okay, the next question is, if you surgically removed a small GIST that was biopsied as 2 by 1.8 centimeter clear margins with a mitotic rate of 7, would you consider this at intermediate risk?
Yes. If we go back, hang on, let me see if I can, give me 1 second, I will go back to that risk stratification and you can see where that would fall. So just by definition right here, you're basically, this is sort of what you're talking about, the situation, right here. So that puts you right in that intermediate category there. If you look at the patients, and if we go back to the full scale here, give me 1 second. Everybody can see this. So right here, you're less than 5, 6 to 10 centimeters puts you at an intermediate risk on that. Looking at the scale, the full scale here. Obviously, if the mitotic index was greater than 10, that puts you right here as high risk. So it's important. It brings up an important question of that an experienced GIST pathologist should be reviewing the pathology and looking at the mitotic index, because it can, depending upon some individual experience, the mitotic index may be different if you have a inexperienced versus experienced GIST pathologist reviewing the pathology. And obviously that makes a big difference in terms of risk.
So the last question is, you mentioned GIST in a certain percentage of patients having other cancers. Is there any research on that? Are GIST patients more likely to have other cancers than patients who have other original cancers?
So there is research on this. Somewhere about 1 in every 6 GIST patients will develop another cancer. If our group a couple of years ago reported the epidemiology of this in the United States, identifying there are certain cancers that are more commonly diagnosed before GIST. There are some that are more commonly diagnosed after the diagnosis of GIST, and there are some cancers that are diagnosed often at the same time as the GIST. These do tend to co-occur, the other cancers tend to co-occur more commonly with smaller GIST, but we certainly have many patients that have larger GIST plus other tumors as well. What is the underlying reason for this? We're currently in my laboratory investigating this exact question, and I don't have anything I can report to you right now, but hopefully within the next 6 months or so, we'll have some better insights into explaining what are some of the risk factors potentially that put patients at more risk of developing GIST plus other cancers.
Okay, great. Well, this concludes the presentation and the Q&A session for today.